Hello everyone, this is Mu'taz Sawi from Mansoura, Egypt. I am moderator and gold member of 3D Cleaning Project International Group and admin of ADC.Inc Paginate Endodontics and one of mentors of ADC.Inc Academy. First of all, I'd like to thank Dr. Sudhir for his invitation to this webinar in ADC.Inc Academy. Today I will talk about 3D thinking, how to think and act in 3D in modern endodontics. Dr. Islam Shahata, one of our mentors today in ADC.Inc Academy and co-founder of Thebes Group, who will talk about tuck back and apical seal, which is so important part in endodontic treatment. And Dr. Muhammad Al-Ajmi, who will talk about coronal seal and final restoration, because you all know that endodontic treatment without good and perfect coronal seal equals zero. Okay, let's start now with 3D thinking, how to think and act in 3D in modern endodontics. We will talk about 5 great categories in 3D thinking. First one is magnification. Second is knowledge of anatomy. You have to know everything inside the tooth before starting endodontic treatment. Third one is 3D cleaning. 3D obturation, and of course Dr. Islam will talk about the tuck back and apical seal, and last one will be coronal seal and final restoration by Dr. Muhammad Al-Ajmi. First category is magnification. We all seeking success and perfection during endodontic treatment. To gain perfection, you have to know the goal of endodontic treatment. The ultimate goal of endodontic treatment is the prevention and or treatment of apical periodontitis, such that there is complete healing and absence of infection. While the overall long-term goal is the placement of a definitive, clinically successful restoration and preservation of the tooth. 3D thinking is new era in modern endodontics, which gathers all steps with new thinking for achieving a successful endodontic treatment, which consists of 5 main categories. Now, let's talk about the first category in 3D thinking, which is seeing. As they said, seeing is believing. You have to see to reach. Reaching what? Reaching every millimeter inside the canal. Magnification is necessary in endodontic treatment. It's important to you as a dentist and mandatory to your patient. 29.5% early retirement because of silent career killer, which is wrong posture. So why? Why to go to your home with back or shoulder pain? So magnification is important to you as a dentist. It's improve your posture during practicing dentistry, personal eye protection, better infection control as it maintains a safe space between you and the patient, especially nowadays with coronavirus. See what you are doing with a good amount of details, better treatment quality. Seeing bigger, treating better. Your patient can see each one of your steps, not only during endodontic treatment, but also in any type of dental treatment. In this photo, you can't see nothing of George Washington clothes details, but with magnification, I think you can be a big dealer of fake money. Before the introduction of the magnification tools, we could feel the presence of a problem. Ledge, perforation, blockage, broken instrument, and the clinical management of that problem was never predictable and depended on happenstance. Now with the help of microscope, we can deal with such complicated cases and the whole procedure becomes more predictable. 55 male patient came to my clinic complaining pain in the upper left area. Clinical and radiographic examination reveals huge caries beside old mesial restoration of 2.5. After removing all caries and opening access, I found small leakage under the mesial composite restoration, which is the main cause of the inside caries. Therefore, the operating microscope enables the endodontist to assess the marginal integrity of restorations and to detect cracks or fractures. The operating microscope can also be useful to detect radicular cracks and fractures, avoiding the necessity of exploratory surgery. 42 female patient referred by a colleague with a perforation during scouting DP canal of tooth 16. The operating microscope has proven to be indispensable for the localization of coronally obstructed canals. Small instruments are used under the magnification to localize the canal orifices. Locating and repairing canal periodontal ligament communications through a delicate and precise intercanal access can only be accomplished with the aid of enhanced vision and illumination from a high-powered magnification, just in this case. Slide 22. The biggest advantage in using the microscope is during retreatment. It's just not easy as you imagine, like removing an old gutta percha. In fact, you will meet a bigger problem than that, such as removal of screw posts, fiber posts, separated instruments, silver points, and amalgam pins, which can be done clearly without magnification. How to increase your learning curve and adaptability to microscope. Introducing an operating microscope into a dental office involves a sophisticated understanding of the role and importance of ergonomic practice. There is learning curve in becoming competent at working at high magnification and performing most procedures indirectly using a smaller mirror. The more the microscope is used, the shorter the learning curve will be and adaptability will increase. You must either modify your dream or magnify your skills. Now we'll go to second category, which is knowledge of anatomy. Working inside anything without knowledge of everything about it is a very big mistake, and of course you can't go for endodontic treatment without having a clear and excellent knowledge about each tooth anatomy. Dear colleagues, you will find a full description for each tooth anatomy in the following slides of this lecture. We will focus on some strange facts about tooth anatomy. Most of canals is ovoid in shape, so there is 35% of the canal will not be touched during instrumentation. 4.2% of possibility to find two canals in upper central and lateral incisors and canine. 23% for lateral canals, 9% for apical ramification. 0.5 to 7.5% of possibility to find three canals in upper first and second premolar, 79.3 to 89.7 for two canals. Worldwide analysis of maxillary first molar for MB2 prevalence reveals the necessity of searching carefully for MB2. 46% of possibility to find four canals in upper second molar. 22% of possibility to find two canals in lower central and lateral incisors and canine. 5.2% for lateral canals. 2.5% of possibility to find two canals in lower first and second premolar. 0% to 0.4 for three canals. 1% to 7% of possibility to find three canals in mesial root of lower first and second molar. 15% for two canals in distal root. 50% to 30% of possibility to find the distal lingual root, which is called into molaris. 0.5% of mesiobuccal root, which is called into baramularis. C-shaped canals are frequent in lower second molar. Third category is 3D cleaning. How to make perfect cleaning to your canals. The root canal is not just a bath in one way. It's too complex, and you have to understand that complexity. Understanding complexity will give you a lot of knowledge to overcome the difficulties within the canal. That complexity includes pulp complexity, biofilm, smear layer, dentine debris. Moreover, we all have to know something very important. It has long been established that a route with a tapering canal and a single foramen is the exception rather than the rule. Let's go back to understanding complexity. Pulp complexity, which may contain accessory canals in coronal, middle, and apical third, additional canals, fins, C-shaped canals, intra or intracanal connections, multiple foramina, did. Such as following cases for Prof. Alfredo Iondolo from Italy shows the real complexity of the pulp. We all know that more than 90% of the canals we treat in our daily endodontic treatment is oval, which means that 35% at least of the canal will not be touched by rotary files during instrumentation. While you can reach more than 90% of canal by irrigation, therefore irrigation is so important during instrumentation. Objectives of irrigation: we have mechanical and chemical function for irrigation and biological function. The biological function of an irrigation is antimicrobial. The mechanical and chemical function of an irrigation: flushing, lubrication, dissolution, and smear layer removal. And the irrigation must have the following characteristics. We have a lot of irrigation solution in field of endodontics, like sodium hypochlorite, chloroxidine, saline, H2O2 for all purposes we said earlier, except removing smear layer, which can be done by ADC and MTAD. Welcome to the world of sodium hypochlorite. Sodium hypochlorite is the most irrigant of choice used in endodontics. Why? Because it's effective antimicrobial agent, an excellent organic tissue solvent, an excellent lubricant, and inexpensive. However, it has some disadvantages, which is highly toxic, highly irritant, highly inflammable, unpleasant odor, doesn't remove inorganic part of smear layer. Extrusion of sodium hypochlorite into periapical tissues can cause severe injury to the patient, and to avoid that we have to know a lot of things like type of needles which exactly should be used during irrigation. Needles used for irrigation could be flat, beveled and notched, closed-ended needles side-vented, closed-ended needles which is double side-vented, closed-ended needles which is multiple-vented. This is shape of needle. So what about the size? In this slide you can see the needle gauge size. You can place the needle easily so near to the apex or so far away. The rule is the larger the number, the smaller the size. You can clearly see the difference between the 27 and 30 gauge in this slide. Flat, beveled and notched needles push sodium hypochlorite 3 or 4 mm beyond the needle, which is so dangerous if you are near to the apex. While closed-ended, wherever slide vented, double vented, or multiple vented, will not or will go just for 1 mm beyond needle, which is more safe for sure during irrigation.